Chapter 22, The Shoulder Complex. Slide 1. In this chapter, you will learn about the common injuries related to the shoulder girdle. These include clavicle and humerus fractures, sternoclavicular sprains, acromioclavicular sprains referred to as a separated shoulder, glenohumeral sprains and dislocations, and rotator cuff tendinitis and impingement. Please use the presentation to guide you in your reading. Once you have completed the readings and corresponding PowerPoints for this chapter, you can prepare your forms. Slide 2. The shoulder girdle is a very complex joint and consists of 5 separate articulations. The sternoclavicular joint attaches the medial clavicle to the sternum. Locate this joint by palpating the clavicle until it meets the breastbone or the sternum. The acromioclavicular joint is where the lateral end of the clavicle meets the acromion. This is at the top of the shoulder. This is the joint that gets separated, as referred by the layperson. The glenohumeral joint is the big ball and socket joint, where the head of the humerus articulates with the shallow cavity of the scapula. This is the joint that is dislocated. The scapulothoracic joint is not considered a true joint, but where the scapula glides over thoracic vertebrae. Major shoulder muscles attach to the scapula. The ligaments are also important in each joint as they hold the bones together to create articulations. Slide 3 through 5. Review the major muscles and rotator cuff using the presentation and the textbook. Slide Slide 6. Review the bursa, nerve, and blood supply for the shoulder using the presentation and textbook. Slide 7. Review the shoulder complex movements for the shoulder girdle using the presentation and textbook. Slide 8. Review the prevention of shoulder injuries using the presentation and textbook. Slide 9. In the next section, you will learn about the assessment procedure for the shoulder. Please read the information from each slide as it corresponds with the textbook. Demonstrations are also available. Considering the complexity of the shoulder assessment, only a few of the special tests will be introduced to simplify the procedure. History. Asking questions about the injury will assist you in understanding the cause and nature of the condition. If the athlete fell on an outstretched hand, he or she may have sustained a fractured humerus, clavicle, or AC separation. If the athlete has his arm pulled back into external rotation, he or she may have experienced a glenoid-humeral dislocation. Most AC separations and glenoid-humeral dislocations cause great pain, so don't be surprised if the athlete reports a high score on his pain scale. Crepitus, or grinding sensations, is an indication of inflammation in chronic injuries and fractures in acute injuries. If there are sensations of numbness or changes in temperature, this means there might be a disruption in nerve conduction and blood flow, warranting immediate medical attention. If the athlete has separated the shoulder at the AC joint, he or she will either have the arm dangling to the side or will be supporting the arm at the elbow. For glenohumeral dislocations, the athlete will be unable to bring the arm to their side because the head of the humerus is dislocated anteriorly and pressing into the front of the armpit against the ribs. Most chronic tendinitis will prevent the athlete from wanting to cross the arms to touch the opposite shoulder or to raise the arms high overhead. Slide 10. By observing the athlete removing the shirt, you will be able to assess the range of motion around the joint, including internal rotation and flexion. If they carefully slide their injured shoulder out of the shirt without raising the arm, you will know they aren't able to perform a normal range of motion. Check the levels of the shoulders. Are they even? If not, is the clavicle deformed? Is there a depression at the sternoclavicular joint? Is there an elevated clavicle at the AC joint? If the lateral end of the clavicle is prominent, this is referred to as a step deformity, indicating an AC sprain or dislocation. If there is a bulge in the armpit and a flat deltoid, this indicates a dislocated shoulder. Again, a deformed clavicle indicates a fracture, and indentation in the upper biceps creating a prominent Popeye muscle indicates a ruptured biceps muscle. Slide 11. The athletic trainer, fitness expert, teacher, or coach can now palpate the areas of pain. This includes the three prominent joints, the sternoclavicular joint, the acromioclavicular joint, and the glenoid-humeral joint. You can also palpate the clavicle and humerus. Palpation of the soft tissue will locate pain sites, abnormal swelling, spasming, and guarding. Refer to the numerous soft tissue and muscles to palpate using the textbook and presentation. Slide 12. Active and passive range of motion is assessed in flexion, extension, abduction, adduction, and internal and external rotation. Slide 13. There are numerous special tests for the shoulder girdle. This section is quite complicated. To simplify, please refer to the special tests listed on the presentation and refer to the corresponding diagram in the book for explanation. Slide 14. The individual can sustain a clavicle or collarbone fracture in numerous ways: falling on the arm, on the tip of the shoulder, or sustaining a direct blow. There will be deformity on the clavicle, with most fractures occurring in the middle third of the bone where it curves. The patient will support the arm and possibly turn the head to the opposite side. Apply an elastic sling, treat for shock by providing emotional support, provide a blanket if the individual is chilled, and elevate the legs if the individual feels lightheaded. Transport the student athlete to a physician. It is not necessary to implement your emergency action plan unless the student athlete is in severe pain or showing signs of shock. Treatment consists of immobilization for 6 to 8 weeks. Surgical interventions for clavicle fractures are controversial. Slide 15. The fractured humerus has a potential of being limb-threatening because of the brachial plexus and artery in close proximity to the bone. There are numerous ways the student athlete can sustain a humerus fracture, including falling on the arm, receiving a direct blow, or during a glenoid-humeral dislocation. Deformity may or may not be present, but point tenderness, pain, and the inability to move will be. Note the x-rays of humerus fractures on the slide. Treat the student athlete for shock, allow the ground to act as a splint, and implement your emergency action plan. It is important that the bone be stabilized to prevent further soft tissue damage. Long-term treatment may consist of surgical intervention and will require 2 to 6 months of immobilization. Slide 16. The sternoclavicular joint sprain is not common in sports. However, it can be very dangerous if the clavicle displaces posteriorly against the airway and the major blood vessels of the neck. The mechanism of injury occurs from either a direct blow to the clavicle or indirect force traveling through the humerus to the clavicle. The signs and symptoms relate to the severity of the injury. In first-degree sprains, there will be no deformity, only some point tenderness and pain. In a grade 2, there will be visible deformity, pain, point tenderness, and the inability to move the shoulder in all directions. In grade 3 sprains, as seen in the picture, there is a complete dislocation and displacement of the clavicle. the sternoclavicular ligament is completely torn. There will be obvious pain, point tenderness, and disability. The treatment consists of RICE. If the student athlete is experiencing shock or extreme pain, implement your emergency action plan. If not, immobilize the shoulder using an elastic sling and refer the student athlete to his physician. Long-term treatment requires possible surgical intervention depending on the grade and the immobilization. Slide 17. The acromioclavicular joint is susceptible to injuries in sport and is damaged from the athlete falling directly on the top of the shoulder or on an outstretched arm. The signs and symptoms relate to the grade of the injury. There's usually point tenderness and pain for all degrees. However, deformity is only evident for second and third degree sprains. Note in this slide how the clavicle is elevated on the left shoulder. This is a third degree AC sprain that healed years ago. However, the deformity is still evident because the ligament is torn and there is nothing to hold the clavicle down to the acromion. This doesn't cause pain, only a visual deformity. Your treatment consists of icing the shoulder and applying an elastic sling to transport the athlete to the hospital. If excessive pain and shock are evident, then implement your emergency action plan. Otherwise, you can have the parent transport his or her student athlete. Slide 18. Notice the gap that is evident in the right X-ray. This shows how the acromioclavicular ligament has torn and the clavicle springs up and separates from the acromion. This is an indication of a second or third degree sprain. Long-term treatment consists of immobilization according to the severity of the injury, followed by rehabilitation. In some sports, a grade 3 would require surgical intervention to stabilize the AC joint. Slide 19. A forceful abduction and external rotation, with the arm overhead and pulled back, is the common mechanism of injury for glenoid-humeral sprains and dislocations. The athlete will experience immediate pain, usually at the front of the shoulder, and decreased range of motion. Apply ice, a compression wrap, and refer to an orthopedic doctor for evaluation and diagnosis. This doesn't warrant an immediate trip to the hospital, whereas the next condition, glenoid-humeral dislocations, do. The same movement in slide 20 that causes a glenoid-humeral sprain also causes a dislocation. The pain in a glenoid-humeral dislocation is often quite severe, especially the first time because the tissues are still tight. However, in recurrent dislocations, the pain is not as severe. The athlete will not be able to bring the arm to the side or touch the opposite shoulder. You will also note a flat deltoid as seen in the next slide. First-time dislocations require the implementation of your emergency action plan and treating the athlete for shock. In recurrent dislocations, the athlete sometimes can reduce the dislocation on his own. Physician follow-up is warranted. Slide 22. Refer to the two clips that demonstrate a glenoid-humeral reduction. The first clip, you will note how difficult it is for the doctor to reduce the dislocation. This is because the musculature is tight and spasmed. In the second clip, the reduction is simple because it was a recurrent dislocation. Unfortunately, 90% of the time, those who sustain a shoulder dislocation will experience another one in time. The long-term treatment and rehabilitation consist of immobilization and extensive strengthening and stretching. Slide 23. Evaluate the pictures on this slide and note how the mechanics involved in each sport are similar in that they require the athlete to raise the arm high over the head. This mechanism is one of the most common for impingement syndrome. In impingement syndrome, the biceps tendon, supraspinatus, and subacromial bursa become impinged under the coracoacromial arch. This arm is large enough to handle these structures. However, when an athlete repeatedly works with the arm overhead, especially with improper mechanics, the structures get inflamed and enlarged, thus causing the decreased space. Slide 24. This injury is caused by overuse and improper mechanics with the arm overhead. It is a difficult condition to manage and often creates not only inflammation but also instability of the glenoid-humeral joint. The signs and symptoms vary according to the degree of the injury. In early stages, pain will oftentimes be present at the beginning of activity and then will subside. In later stages, pain is present at all times and prevents athletic activity and even disrupts activities of daily living. Treatment requires a reduction of activity and aggressive approach to reduce swelling with ice massage, anti-inflammatory meds, ultrasound, massage, and possibly a cortisone injection. It is imperative that the athlete be evaluated and taught proper mechanics. Rehabilitation is extensive and requires strengthening of the rotator cuff muscles, the core, and the scapular stabilizers. Stretching the anterior muscles is also necessary to correct postural misalignment. Surgery may be required for severe impingement syndrome and includes debriding the joint and reattaching a torn rotator cuff. Slide 25. A biceps rupture occurs when the athlete forcefully contracts the muscle against resistance. This is the most common in gymnastics and weightlifting. The athlete will hear and feel a pop, experience pain, and weakness. A noticeable deformity will be present. Apply ice, an elastic sling, and refer the athlete to a physician. Depending on the athletic requirements, the individual may or may not need surgery. The brachialis is the primary elbow flexor, thus many athletes can function without the biceps. Slide 26. Refer to this very comprehensive section of the chapter to understand the scope and sequence of shoulder rehab. Explanations and diagrams of exercises are included. Slide 29. Acute conjunctivitis, also referred to as pink eye, is a highly contagious bacterial infection that can quickly spread through an entire team or physical education class. The individual will complain of pain in the eye, tearing, redness, and swelling. Sometimes itching and burning are present. Refer the athlete to a physician for evaluation and antibiotic treatment. Be sure your athletes and students do not share towels, and they also must engage in proper hand washing to prevent the spread of pink eye. Slide 30. Throat contusions are rare but dangerous. Clotheslining is a type of trauma where the athlete is struck in the throat by another player's outstretched arm. Such a force can cause damage to the carotid artery. The athlete may experience pain, spasmodic coughing, a hoarse voice, and experience difficulty in swallowing. He or she may also have difficulty in breathing. Fractures of the throat cartilage are rare, but will demonstrate as extreme difficulty to breathe with frothy blood coming from the mouth. Treatment consists of protecting the airway and monitoring symptoms. Cold should be applied. Any signs of increased swelling or difficulty breathing warrants immediate referral to a physician and the implementation of your emergency action plan.